patients who are doing well, and even though they have large curves, as far as I'm concerned, they would be the perfect candidate to have a perfect surgery, but medically may not be necessary. So it's something which they can consult with the surgeon about the next step. So it's important for us. Yeah. So as you're coming in, as you joining the webinar, we have a Q&A board down there. So you can just type in where you're from so we know how far we're reaching and teaching this morning. This is our monthly free webinar series. We have been doing this since 2017. Yeah. Every month, trying to bring incredible speakers and learning more and more about scoliosis. And it's an open door. And now I stopped counting around country 98. I still get new countries, but we're definitely reaching professionals for over 100 countries. Each lecture, we have 20 to 30 different countries, sometimes 40, depends on the topic. And I really enjoy that outreach and sharing information around the world, even though the guidelines might be different in each country, but it's important to learn more about it. So usually people coming in the last minute. So as you're coming in, put your little country, put your country and perhaps even your profession in the Q&A board. Say hello to us. And that will be great for our speaker and for myself to see how far we're reaching and teaching this morning or this afternoon. Depends on where you're coming from. And I'm just going to check a couple of things to close here. Good. You must be very busy with your practice.
It's always busy, between work and life. It's
Yeah.
always busy.
You still play hockey? Pick up hockey?
I don't. I just coach now, so
Oh, that's nice. That's nice.
better.
You probably missed the ice though. You're
No,
still on the ice.
I'm still on the ice lots.
Yeah, yeah, yeah. Yeah. Both of my boys were, and one of my daughter was in hockey. And another one was figure skating. So all my life I was sitting in a
Sure.
very cold arena,
Yeah.
which, but I love skating too. So as you guys coming in or as you coming in, please visit the Q&A board and fill it up where you're from. Say hello to us. And we'll start in about 5 minutes with a little bit of introduction, and then we're going to go on to the webinar. Yeah, we have been trying to um, invite more and more surgeons to let us know uh, there's so many different surgeries are available now, not just the pediatric, but the adult population too. And of course, we have patients who would say that's the best decision of my life. I wish I'd done it earlier. And sometimes we hear the opposite too. So it's very difficult decision, I think. And the more we know about it as professionals, the better it is for the patients too.
Yeah, I agreed.
And I'll do some, yep, they're coming in. Since I can't recognize all the names, I see some regulars, but please use the Q&A board and let us know where you're visiting from, okay? And we like to see your country listed in a Q&A board and later on using it for the questions as well. So Q&As, questions will be only answered through the Q&A board. Nice to see everybody coming in, and we're going to start in a couple of minutes. Any holidays for you coming up?
Um, so I'm on a bit of a break right now, and then I've got a week in the start of August.
Okay. Okay. That's why we were so lucky to have you. That's great. Alrighty, they're coming in now with bigger numbers. Always last minute. So Welcome, everybody. And as you coming in, please add your country to the Q&A board, fill it up, say hello to us. Let us know where you're watching us from, where you're learning today. And I'm going to start a little bit of a introduction, and then we go into the lecture. Okay. Yeah, still coming in. We just had a webinar 2 hours ago for the Lyon Method French School as well. So many of the students are webinared out. And they said though they were gonna come. So we have a hello from North Carolina. Hello, Jay. Nice to see you here back again. And please fill up the Q&A board. Where are you coming in today to visit SSOL and having to take part of the free webinar series? You can use the Q&A board, and later on, please use that for your questions as well. So I'm going to introduce the platform you're on. It's called the Scoliosis and Spine Online Learning. We opened this platform um, in 2017, 2018. We have since then regular webinars every month. You can always check the upcoming webinars here. And you can also subscribe. If you're not live in a webinar session, you can check out the library. And we have many global experts and presenters you can learn from. We have surgeons who presented, physiotherapists, researchers from many different countries. And it's important for us to continue the education and share all the learning around the world regarding surgery, bracing, scoliosis-specific physiotherapy, and also the latest research, what's coming up in the scoliosis and spinal disorder field. Once you choose a lecture, you can check the programs and the recorded programs in the SSOL library, which is open 24/7. So feel free to visit us anytime from anywhere and keep on learning, because we believe that learning never stops in a scoliosis field. So we're looking forward to having you in the library, looking forward to having you on a free webinar series every month. And we like to have you come in and learn more about scoliosis and spinal disorders. We have hello from Toronto, United States, Canada, Israel. And if you haven't picked, haven't wrote your country in there, please do so. It's nice for us to know how far we are reaching and teaching, and it's great for us to know that you're coming to visit us on a regular basis. I'm very happy to introduce today's speaker, Dr. Christopher Nielsen. Today's topic will be adult surgical indications and patient selection in a scoliosis care. And I'm very happy to have a Canadian lecturer today, a Canadian surgeon who can give us guidelines for our country. I'm from Canada as well, so I'm looking forward especially to this lecture. And this lecture is going to be focused on the surgical decision making in scoliosis as the patients transition from pediatric to adult care. Dr. Christopher Nelson is an assistant professor in orthopedic surgery at the University of Toronto and practices at the Toronto Western Hospital, University of Health Network. His clinical focus in spine surgery, treating a wide range of spinal pathologies across the cervical, thoracic, lumbar, and sacral regions. His areas of expertise include adult spinal deformity and complex revision surgeries. Dr. Nielsen completed medical school and residency in orthopedic surgery at the University of Calgary, followed by fellowship in complex spine surgery at Toronto Western Hospital, where he has been practicing since 2018. He's a surgeon, educator, and currently serves as a Spinal Fellowship Program Director at the Toronto Western Hospital, Orthopedic Director of the ACPAC program, and the Spine Subspecialty Lead for the Canadian Orthopedic Association. I would like to welcome you to the SSO and Spine online learning, and thank you for taking the time to present to us today. Anybody coming in, the Q&A board is the only way to ask questions during the lecture, and feel free to type it in. Thank you, and ready for sharing the screen.
Okay,
Well,
excellent. Okay, well, thank you very much, Andrea, for the invitation this morning to come in and share my sort of approach to surgical decision making in adult scoliosis surgery. And so, for the purposes of today's talk, I do a little bit of speaking for one of our companies, but otherwise, I don't have any other relevant disclosures. Okay. And I'm going to sort of approach things from the adult spine perspective. And it's pretty obvious, in my world, anyways, where I see people who come to me that have scoliosis for the better part of their lives, whether they're in their 20s or into their 60s, that scoliosis does not equal surgery. Okay, and when we start to think about the holistic approach to scoliosis care, it becomes quite complex. And so nothing that we do with respect to treatment of these patients is easy. And in fact, the management of scoliosis, requires understanding both from the patient perspective as well as the provider's perspective and how to best treat our patients so that we can optimize their overall quality of life. And what I can assure you is that, if the decision for surgery is made, it is not easy. Doing scoliosis surgery is hard work, both physically, but also mentally. And managing patients in and around the time of surgery requires a lot of planning and it requires a lot of other healthcare providers. So it's very much a multidisciplinary approach in order for us to be able to provide surgery in a safe and effective fashion. And so really today, what I sort of want to, talk about is, my approach or, the approach of many adult surgeons as to which patients are going to benefit from surgery. Now, scoliosis is quite heterogeneous in terms of the etiology. And for many people, if you're involved in the care of pediatric patients or in the care of adult patients, the etiologies are different, and oftentimes the presentations and indications for surgery will be different as well. And so we can have, scoliosis and deformities that are congenital in nature due to sort of formation abnormalities during sort of the neural axis formation in utero. We can have neuromuscular causes of deformity where there's an underlying disorder in the neurologic system that is driving a complex deformity. There are sort of idiopathic, and sort of as the idiopathic patients age, they often develop secondary degenerative changes within their scoliosis and deformities. And then we have some, acquired causes of deformity, and I'll get a little bit into, the definition of adult deformity, but it doesn't necessarily have to include scoliosis. In fact, sometimes there's no curvature in the coronal plane, and we're dealing with a quite kyphotic or something that affects the sagittal plane profile. We have our standard degenerative cases, and so these are the scoliotic curves that develop as the spine degenerates, and they behave a little bit differently, and they present a little bit differently. We can see sort of acquired or post-traumatic causes of deformity, and so in some older patients where there's poor bone health, they can have multiple compression fractures, which then lead to deformity and the resultant changes with that. Um, and we get people have already had surgery, and yet, because of, the surgery that they've had, they may have what we call an acquired deformity or a flat back deformity if they haven't had attention paid to the realignment of the spine. And lastly, we see deformities are part of an entire syndrome. And so patients, can have syndromic scoliosis, and there's, certain challenges that arise when we're making decisions and treating these deformities as well. And so, what I'm trying to sort of illustrate is that it's quite a heterogeneous population, and for adult surgeons, we sort of lump everything into, one basic term, which is adult, spinal deformity or ASD. But the etiologies can be very different, and decision making can be nuanced as a result of that. So the spectrum of adult spinal deformity can start in childhood with, congenital neuromuscular, idiopathic, syndromic causes, but we can also see it, manifest in adulthood as a result of inflammatory conditions, degenerative conditions, traumatic, or iatrogenic, which is something that we deal with on a regular basis in patients that have had fusions, a number of years ago. So in order to really think about, deformity, we have to think about what is the body trying to achieve in sort of overall global alignment. And so the body's number one priority is to center the head over the pelvis, over the feet. And why is this? Well, first off, if you're in a disadvantaged position, you may not be able to maintain horizontal gaze. And when I say horizontal gaze, I mean it's the ability to sort of look forward when you're standing and walking. And so some people find themselves in an alignment where, they can't see anything but the floor. And so for them, walking around becomes increasingly more difficult. It also aids in balance. And for anybody who wants to try, you just stand up and you try to sort of stand on one leg with your, head a foot or two over to the side and see how easy it is to stand up. But it really is not. And it increases the energy expenditure. So once you get out of what we call the cone of economy, which is the ideal alignment for, everyday activity and locomotion, you're going to increase your energy expenditure just for walking by about 2 to 3 times. So what is adult spinal deformity? Well, it's an abnormal curvature of the spine. And we sort of understand that, in a frontal projection or an AP or a coronal, so when you're looking straight on to the spine, it should be straight. As we look from the side or the lateral or sagittal plane of the spine, there's the normal sort of lordotic and kyphotic angles. So your cervical spine should have lordosis, your thoracic spine should have kyphosis, and the lumbar spine should have lordosis. But anything that is resulting in abnormal alignment, whether it be in the coronal or the sagittal plane, is essentially deemed or termed adult spinal deformity. So we lump in sort of all of these different etiologies into one sort of catch-all term. And really, the difficulties, especially as you're aging, so, we don't see it as much in sort of our younger sort of populations, the late teenagers, early 20s, and into 30s. But certainly as people get older and there becomes secondary degeneration or they have degenerative scoliosis, it really causes difficulty with people's ability to stand straight. Oh, oh, cool. That in fact, it's the sort of sagittal plane deformity that patients really struggle with. And so, as the spine degenerates, oftentimes you end up with a more forward posture, but this can be really sort of accentuated classifications of deformity that exist, and specifically within pediatric populations. Probably the most commonly used is going to be your Lanke classification. There's also a King classification, but I'm going to skip over those, and I'm just going to talk about the classification in adult spinal deformity, which is the Schwab classification. And what I really want to sort of draw your attention to is difference in sort of the Lanke and King classifications that focus primarily on sort of your coronal plane abnormality. The Lanke does include a sagittal modifier. Within the Schwab classification, your thoracic, lumbar, and double curves, they do take into account the coronal scoliosis, but there's an entire classification for a normal coronal alignment and simply a sagittal plane deformity. So when I see patients in my clinic that are coming to see me, and the first time or two that we meet, the question that I continue to ask myself is, can I make you better? And that really is the way that I approach things. So I look at it as a holistic approach to patients. And what I try to determine is, how much runway do I have to work with? And this comes down to determining how big of a deal or how much effect is the deformity having in people's lives. And, for those of you that regularly manage or see patients that have scoliosis, you'll know that there's a wide variety. For some people, they don't have a lot of issue. They don't have a lot of pain. It doesn't affect their overall function. They're doing, most of what they want to do in life. And for patients that are functioning highly with their deformity, I consider that to be a short runway. There's not much room for me to make that patient better. When patients have a lot of disability as a result of their deformity, then there's a lot of areas in which that I feel as though I can have, positive impact with a big surgery. So that gives me a lot more runway to work with. So that's simply, one part of the equation, is trying to decide, from my standpoint, with my knowledge and understanding of what I'm going to do at the time of surgery, can I make you better? But, for me to be able to determine if that's possible, I really have to take the time to talk to my patient and decide, and understand from their perspective what is the impact of their scoliosis or deformity on their life. And then what are their expectations? Because those are two very different things. So as I tease out all of the questions around pain and function and self-image, and neurologic function and all of these different sort of components that I'm going to be looking at, I could get the objective information of, can I make you better? But the most important part is the subjective part of the patient's expectations. And that's a different question. And I often ask patients, in their own words, tell me what needs to change in your life for you to be happy following a surgery. And, what comes out of their mouth is sometimes, surprising, even after you've asked them a lot of different, questions about their overall objective function. Sometimes their expectations are very much different, and their expectations will dictate whether or not they're satisfied with their surgery. So I'd like to take a bit of time just to think or talk about what are the factors that come to play when we're trying to make decisions as to whether or not a patient is a candidate for surgery. And for myself and my practice, there's really five main indications. Number one is pain. And pain is a subjective experience, and yet we try to quantify it in objective ways through, pain scales. And so when I'm talking to patients, I'm going to ask some questions about back pain. I'm going to ask some questions about leg pain. And I'm going to ask some questions about, their pain experience, at rest and with activity, and sort of on a day-to-day basis. And I try to figure out, is your pain something that is really negatively impacting your life? And so one of the easy things to really sort of tease out is, are you taking pain medications? And for many patients, they come in and, because their pain is terrible, that they're already opioid dependent, which is an unfortunate position to be in, but it's also an indicator that, for them, pain is quite a, limiting factor. Secondly is going to be neurological symptoms. Now, for the most part, most of our patients with scoliosis and deformity do not have any or rarely have serious neurologic sequelae. And when I say serious neurologic sequelae, I really am talking about spinal cord function. There are going to be a few patients, however, that due to their type of deformity, that they are at risk of developing myelopathy. And myelopathy is simply a term to say that you have an unhappy spinal cord, that the function of the spinal cord is not normal. And for, a subset of patients typically are congenital scoliosis, and sometimes are sort of neuromuscular or syndromic. They become more at risk, and there's specific curve characteristics that put these patients more at risk. And the neurologic symptoms, we'll get into it, but sometimes they become the main driver of surgery. And unfortunately, when they become the main driver of surgery, it typically means that that surgery is going to be of significantly higher risk. Third, we look at balance, people's ability to stand up straight. And I've already spoken a little bit about the body's priority to sort of maintain within the cone of economy. But for some people, this becomes a real challenge because they have a fixed deformity, meaning that no matter what they do, there's no way that they can, maintain their head within the cone of economy. Fourth on our list is quality of life, or function. And this is really seen in our sort of aging adult population. And we'll talk a little bit about how this affects, patients, but, it's been very clear in, multiple studies that, the impact on quality of life of adult spinal deformity, is similar to and sometimes worse than major other medical health states, such as having cancer or heart disease or diabetes. So we know that adult spinal deformity can be a major impact on the health-related quality of life of our patients. And lastly, and certainly not least, is self-image. And so self-image, has been largely studied in the sort of adolescent population, and there's lots of literature to suggest that self-image improves across surgical patients. Um, and there's more evidence that is, being published more recently in our adult population and the aging population as an important driver of outcomes for the older patients as well. So these are really when I think about can I make you better, these are really the domains in which I need to sort of investigate, understand on a patient by patient basis, you know, can I make a difference in one of these domains? So let's break it down. So I'll try to do it on a case by case basis, and these are all my patients. But this was a young girl. Clearly had scoliosis surgery in the past, but came to Canada from the Ukraine about 4 years prior to me meeting her, and she'd been having back pain for a while, but it was unbearable to the point. She told me that in order for her to get around her house, she would crawl. That standing up was, largely impossible for her, and her pain was debilitating. She did endorse um, frequent urinary accidents, which, always piques our interest. And, we think about, what is pushing on what. And so, um, when I thought about this patient and I met her and, she told me her story and I thought about, can I make you better? Um, in my mind, I felt as though surgery had a very good chance to improve her quality of life. And why do I say that? Well, if we look at sort of the average pain scores before and after surgery, virtually all of our major sort of cohorts that we've studied in different sort of regions of the world would all report that the average expectation of post-op pain following the deformity surgery is somewhere between a 2 and a 4 out of 10. Okay. And so this is what I regularly tell my patients. And when I talk to them about their pain and I say, what is your pain at rest? What is your pain with activity? When we do all of this stuff, in my mind, I'm really thinking this, that if your pre-op pain is less than 5, then I'm not sure that my surgery is going to make a meaningful difference on your pain. Versus if your preoperative pain is regularly above 5, then I have a pretty good idea that if I'm doing surgery for pain as a main indication, that, I can tell or educate my patients that my expectation is that your pain will improve. Depending upon the magnitude of pain, it might be a huge improvement or it might be a small improvement. It also becomes important when in terms of educating patients, if the reason they're having surgery is not primarily for pain. So some people will have minimal pain, but the main driver is going to be self-image. They just have to understand what the expectation of pain is post-operatively so that they can then sort of make an educated decision as to whether or not they still want to have the surgery. Because no pain after surgery is not possible. And this is what I tell patients. If you're going to have this surgery, you will have back pain. So we did this surgery, and what I can tell you is that this young lady was very, very happy. So happy, in fact, that the second day after surgery, she jumped out of bed when I came into the room and actually gave me a hug. And I still see her, and she still continues to do well. She required a realignment surgery as part of the procedure, which I won't get into sort of details of surgery, just more about the surgical decision making and indications. So that's our pain. Neurologic function. Now, this is a different sort of, animal altogether. And so this was a young lady that had come to me, was initially from Ghana, and actually had been braced as a teenager for a number of years. And for congenital scoliosis, there's really no clear indication for bracing. It's more for our idiopathics. Um, but unfortunately, she started to notice numbness in her legs and was starting to feel as though she was a bit unsteady on her feet. She had some urinary frequency, which means that, in some instances, this can be a sign that there's a neurogenic component to the bladder. And when you examined her, she actually had signs of an unhappy spinal cord and thoracic myelopathy. Now, the question is, what to do and when to do it. And so this is when I have to have a, clear discussion with patients that their spinal cord's not happy. And so generally speaking, we're still sort of taking our time and, determining when the best time for surgery is. And it really comes down to, a shared decision making between myself and patients as to when that is. And that really is because in these situations, we know that the risk of surgery is very high. And so patients that come in with already impaired spinal cord function, and they come in with very sort of short and sharp curves, as we see in congenital scoliosis, they end up being in a high risk category. And a high risk category is not insignificant. So it means that there is real risk during surgery that there can be neurologic changes and impaired neurologic function post-surgery. If we take the biggest, and probably the best literature to date, which is the Scoliosis data, it would tell us that, following complex surgery in these cases, that 23% of people have impaired neurologic function following surgery, of which 10% is still present at the 1 year mark. Okay, that's the best data we have, but it tells us that it's a significant risk. Nonetheless, she and I had, multiple discussions and ultimately decided that surgery was the best thing to halt the progression of her impaired neurologic function. And we did surgery that was quite complex. And during surgery, we had, you know, changes to our neuromonitoring, which is almost expected. Um, and we've managed to stop the progression of any neurologic function. In fact, the numbness in her legs was better. Um, but of all my patients, she's not terribly happy because she has a significant pain um, and post-operatively. And so here was somebody who didn't have a lot of pain before surgery, and we did the surgery because of the neurologic function, but because of the consequences of surgery, she hasn't been particularly happy with the outcome. She's okay with the sort of cosmetic part of it, but there's elements of the surgery that have led her to, be not happy. Now, if we're thinking about our coronal and sagittal imbalance and trying to have people in the cone of economy, I'll share this case of a you know advanced age, so a 78-year-old female, and she was of Italian heritage, and all she wanted to do was to be able to be in the kitchen and cook for her family, and that was really important to her. And she can no longer do that because she can't stand. So 2 minutes was the maximum that she would be able to stand or walk, for that matter. And for her, the impact on her quality of life was massive. So she really couldn't go out. She was limited to her home and limited to people coming to see her. But despite being 78, she was essentially healthy and quite robust. Um, Now, there's an element of frailty that goes along with being 78 that's, age related. But from an overall medical standpoint, outside of her advanced age, um, we knew that, doing surgery for her came at a sort of low risk because she didn't have pre-existing, heart or lung issues to deal with. And so it goes back well over 20 years now, the understanding of the impact of imbalance, and specifically for the aging population, it's positive sagittal balance, meaning that you're in a stooped forward posture. And what multiple studies have ultimately shown is that it's in a linear fashion. The more forward you are, the worse off your function is, and the more disability it imparts to the patient. And so, for this patient who just wanted to be able to stand up, we had to do a big surgery because she had a rigid deformity, and in order to be able to, get her in an upright posture, it was a full day's work. Um, but she's one of two patients, she's one of two patients that came to the clinic afterward and gave me a big kiss on the cheek at 3 weeks or 3 months in her first post-operative visit because she was so happy that she could stand up. So I alluded to the impact on health-related quality of life for patients, and this is really where a lot of you know, um, the research in adult deformity surgery has been. And so this was a early 60s patient. She'd been diagnosed. She had a small idiopathic curve, but um, over the past 10 years, she'd been having worse and worse pain, and we can see sort of at the bottom of her lumbar spine that there's secondary degeneration, and you can appreciate how she both is imbalanced in the coronal as well as the sagittal plane. And now she's to the point where she can't walk for more than or stand for more than 5 minutes. And you'll continue to hear me say, but this significantly impacts people's sort of life and social life specifically. Um, so multiple studies. So this is, a paper that, we wrote out of the AO spine deformity group, which is the PEDS group. There's a large, two large cohorts of US based um, outcome studies for adult spinal deformity. This is one that's out of the European spine study group. And so multiple large cohort studies in adult spinal deformity have all shown the same thing, is that surgery, when people have significant disability related to their deformity, surgery has a good chance of improving patient function. And so, in our study, we looked at the Oswestry Disability Index as an outcome measure for this surgery, as well as other things. But the ODI score is a very commonly used patient-reported outcome measure that has been validated across multiple sort of disease processes within spine. And what we found is that regardless of patient, regardless of age, regardless of indications, about 70% of patients had significant improvements in their overall function as measured by the ODI. But what does that actually mean to the patient? And so when we're trying to understand the functional capabilities of each patient before surgery and trying to, tell them or educate them about what the expectation should be after surgery, we can break down some of the core sort of functional processes that people do on a daily basis. And really, it's standing and walking. Okay, standing and walking are the two big things that every person needs to maintain for a decent quality of life and to remain independent. And so if we looked at that cohort of patients, which was over 200, at baseline before surgery, about 45% deemed themselves to be in a bed-bound status. They're standing and walking for any period of time was almost impossible. And if we look at, post-surgery, you've decreased that down to, about 18%. Okay, so not to zero, but significantly more people are doing better. If we look at the walking greater than a mile at baseline before surgery, only 1 in 4 patients would be able to walk a mile versus after surgery, it's up around 60% at both 2 years and 5 years. So you can see that, you're making a significant improvement for many of the patients. When you look at social life, and only 1 in 5 patients reported a normal social life before surgery, that was well over 50% at 2 and 5 years. And so these are really the functional questions that we're trying to ask patients and trying to understand, how do we think surgery is going to improve? And when you have people that come in and when they have significant impairments, it's a lot easier for me to have, honest discussions about what my expectations following surgery are, if they so choose to go down that road. And so following surgery, for this patient, we've been able to wean down her opioids. Her standing and walking is, certainly much improved. She's about a year and a half after surgery, and she's, doing well and quite happy that she went through with surgery. And you can see on her post-operative films that we've managed to restore her hand within the cone of economy, both in the sort of frontal and sort of lateral projections. All right, so the last part that I'm going to sort of take, the last of the five sort of areas that I sort of really sort of focus on is self-image. And so this is a gentleman who got referred on to, and this in and itself is a crazy picture because the AP is essentially an axial view of the thorax, and so we're looking straight down in his chest cavity because this patient has ankylosing spondylitis. And, over the past 10 years, what he tells me is that, maybe about 10 or 15 years ago, he was relatively straight and now he's completely stooped forward. And this is part of the inflammatory process of ankylosing spondylitis where it fuses the spine. But unfortunate for him is his spine fused in a very, very um, disabling position. And so when I tell you he couldn't, when he stood up, he could not have horizontal gaze. He stood at the floor, and so just standing and walking was almost impossible. So when we look at the impact of self-image, and this is a study that is in publication now that we presented on, and have looked at sort of the impact of deformity on patients' self-image as reported by the SRS 22, our patient-reported outcome measure. When we look at sort of our normal, if you remember the N in the Schwab classification, are patients that don't have any coronal deformity, so they just simply have a sagittal plane deformity. What we see is that their mean preoperative score, they have a lower self-image score than the patients that actually have a coronal plane. So patients that have simply a sagittal plane deformity only, in fact, have lower self-image scores than patients with scoliosis as part of their deformity. But what we see is that following surgery, they all improve from baseline. And when we look more specifically at the specific type of N patients, is what we find the patients that have the most positive sagittal alignment. So SVA is what's called the sagittal vertical axis. And so a plus plus SVA means that they're, anywhere from 10 or greater centimeters positive. So they stand more positive than other people. And so the lowest score preoperatively are in patients that have the most sagittal plane malalignment. And it's, part of the conclusion of this paper that is in publication is that the sagittal plane really drives the self-image concerns of our older patients. They don't like being stooped forward. So for this young gentleman, he underwent surgery. We had to, because his spine was completely fused, we had to cut two of the vertebra to get a realignment. But now he can stand and he can stand straight and he can walk and he has horizontal gaze and he's been quite happy. So, as we sort of wrap up the talk part of things, I just want to sort of go back and talk about how are we making our decisions, or what are the things that we're looking at. So, when it comes to pain, I think the important thing for myself to understand is that after surgery you're going to have pain. It's just how bad is that pain, and typically it's about a 2 to 4 out of 10. And so, for patients that are considering this type of surgery, um, it's good for them to know if they've got pain that's, in the sort of 6 to 8 range, they can expect probably a 50% improvement. If their pain is around 4 or 5, well, the pain improvement's probably not going to be very much. And if they have no pain, well, doing surgery is going to be a pain inducing process. And so I would never ever promise somebody that tells me they have no pain that they're going to feel the same way after surgery. When we look at the neurology or the neurologic symptoms that patients have, the biggest thing for us is to determine spinal cord function. If there's impaired function, which doesn't happen very often, but it does happen, oftentimes that influences their decisions to go forward with surgery. Okay, because people are going to lose function if we don't actually do surgery, but it also means that that surgery is going to be high risk. Um, The coronal and sagittal imbalance part of it, it really impacts people's quality of life when they can't stand within the cone of economy. And so doing surgery needs to be targeted at sort of restoring that balance. We look at our quality of life and functional impairments. When we take some of the basic functions on a day-to-day basis, we can look at, the, walking tolerance or standing tolerance or sitting tolerance or social life, and we can look at these domains and we can provide patients with, a a clear sort of expectation following surgery, and by providing those expectations, and it allows the patients to be informed and really sort of facilitates the shared decision making between myself and patients. Lastly is the self-image. And, it's not just for younger patients, it's for older patients. People don't, like the way that they look. And when we ask patients, how do you feel about the shape of their back? Virtually every patient says, I don't like it. Now, it doesn't mean that every patient would be willing to undergo a surgery. For some people, they don't like the shape, but it's not a big deal. For others, it's a medium deal. For, some people, it's a really big deal. And one of the main reasons that they're willing to undergo surgery. Now, I really like this sort of natural history study. So Stuart Weinstein was a pediatric orthopedic surgeon out of Iowa, did this natural history study of patients. And this was after 50, so 50 years. And this is exactly what I tell my patients. I tell them, patients with untreated AIS, you can function well. That means that when it comes to having, good jobs and career success and relationships and families and happiness, scoliosis is not going to impact that. So that's not what's going to, your scoliosis is not going to have a negative impact on your ability to, live life as an adult. What you can expect, and I tell my patients, is compared to your friends and family that don't have scoliosis, you will have more pain, right? We know that. And so they can also have some more subjective pulmonary issues, and they can be at risk of sort of progression, but they will have more pain. And so this is where I transition into, and it doesn't matter which patient it is, they all need to do some form of exercise, some form of physical therapy program to maintain their core and back muscle strength, because for all people, like every Canadian, is recommended to focus on core and back muscle strengthening for low back health, and that goes for anybody. anybody, if you are struggling with low back pain, the first place to start is always with core and back muscle strengthening. So I really like this study and I refer to it for every patient that I have. And so I think hopefully what you've taken home from this talk is that, I really sort of look at this as from a holistic approach. And so I may have a black and white image, on the computer screen. I get to see the x-ray and I can measure the magnitude of the scoliosis. But, that does not mean that surgery is going to be the right choice for that given patient. And so, um, you know, it I never make a decision on surgery on the first visit. The first visit is always just a fact gathering mission for me, for the patient, providing some education. I need to understand, what is going on in their life. How does this, deformity impact their life, right? And then I really sort of want to delve into the expectations. And sometimes I ask the question to the patient, what needs to change in your life? And they can't actually give me an answer. And so I tell them, I said, well, you need to think about this. And, the next time we see each other, I'm going to ask you again. I'm going to say, what needs to change in your life for you to be happy? Because I really need to understand that, right? Um, and, I can't, um, you know, meet certain expectations. It just it's impossible. There are limitations with surgery and the expectations and the outcomes following surgery. And so if I get myself into a situation where patients realistic or expectations are unrealistic, then I either have to, try to realign those expectations, and that's going to take more than a few visits, or I can't operate because it's a recipe for disaster for patients whose expectations are unrealistic. Doing surgeries is not a good thing because it just means that the patient will ultimately be unhappy. And there is always a role. So every patient I tell to do exercise, and so I'm a big believer in sort of movement. Motion is lotion. That you have to keep on doing things. You have to stay strong, and I tell people it's not a quick fix, but ultimately you're going to be better off for staying in sort of good physical condition and having sort of good core and back muscles. So, in conclusion, um, the first thing I'm doing every time I see a patient is trying to figure out what type of runway do I have to work with. Okay, if I've got a long runway, if the patient is really disabled, then chances are there's something that I can do that's going to be beneficial. I'm trying to understand the patient's expectations. Where is that bar? What has to change in their life for them to, be happy? And, if their bar is low, if that patient says, well, right now I can't stand and walk, I just want to be able to walk for 10 minutes, then that is something that I feel comfortable I can, meet that expectation versus if the patient comes in and tells me, well, I want to, go back to be, a competitive figure skater, gymnast, these are things that I know that surgery, even a good outcome from surgery, that you're not going to be able to do those things afterwards. And so if I do my job and I do a good job picking patients and sort of, you know, deciding, in a shared sort of way, patients that are going to do well from surgery, then that is going to lead to happier clinics for me and ultimately happier patients. And I think that's the biggest thing is that at the end of the day, um, you know, surgery doesn't or scoliosis doesn't equal surgery. And we have to really sort of take our time to figure out how we can help patients the best way to maximize their quality of life. And for some, it's surgery. For others, it's clearly not. And so, hopefully today has provided a little bit of an understanding of, the process that, I go through as a surgeon to make decisions as to whether people are surgical, and it's certainly, regardless of whether you're surgical or not, remaining active, having specific therapy is always a really important part of it. So thank you for your time and attention today. And I'm more than happy to answer some questions.
Thank you very much for this incredible lecture. You really cleared it up for us with all the segments you presented. And we definitely have already many questions. And I think that will clear up a lot for our visitors in terms of when is the right time to pass the patients on from conservative care and have a consultation with the surgeon, as well as how to work with the patients on a long-term basis to get them ready if there's a surgical indication going on. We have questions. Can you hear me, Bill? Okay. We have
Yeah, I can hear you just fine.
okay. We have questions regarding an age group when the pediatric patients become a little bit older and they're not
Yeah.
into the surgical range in the adult spinal care, but they aged out of the pediatric care. Um, for example, a 60 cup degree, 19-year-old patient who's still flexible, still able to potentially be treated in some places with a pediatric surgical team, but now, especially in Canada, there will be the adult surgical team looking after that patient. What would be your recommendation for this age group in a gray zone?
Yeah, I mean, from my standpoint, it's not a gray zone. If you want to think about, is the scoliosis big enough for surgery? Well, yes, it is. Like there's not a question, at 60 degrees if the scoliosis is something that, would benefit from a surgery in terms of managing the curve itself. Um, but these are challenging ones, and these are patients that come to my clinics, and guess what? Mom and dad are still in tow, and mom and dad have ultimately been a large part of the decision making for this patient. And now all of a sudden you have an adult who has their own opinion, and oftentimes that's very different from what mom and dad have. And so
It looks like we lost our lecturer. Hopefully, he will be back. Until you are able to add more questions to the Q&A board, we have some of the questions regarding specific surgical approach, as well as what happens with the degenerative changes. And if we cannot get him back online, I'm going to pass on these questions and I'm going to try to have them answered for you. So you can always send your question ssolglobal@gmail.com, and we'll be happy to pass it on to the presenter. And Dr. Christopher Nielsen is in Canada. He's following the Canadian guidelines of surgical indications. So if you're tuning in from another country, you might have different approaches, different guidelines in the local healthcare teams. So we'll wait for a couple more minutes. Hopefully, he can get back online. I think the internet was a little bit choppy for a couple of minutes, so we're gonna see if he can come back. Until I'm really glad that you tuned in from any part of the world. We're gonna have a little summer break and going to have in September a very important lecture on Lenke classification, Lenke-Aubin classification of three-dimensional classifications for surgical indications of scoliosis. We all know that scoliosis is three-dimensional, but now we have this new classification through the surgical view and the lens. Okay. Not sure what's happening, so I'm gonna try to see if we got some email, and if by any chance it's not possible to have our lecture back, I'm glad that you enjoyed the presentation. We have great thank yous from Taiwan, and I'm glad that you were able to visit us from many different countries. And if you wanted to send us your question by email, ssolglobal@gmail.com, we can try to get an answer for you. Not sure what happened here, but hopefully nothing major, just a little bit of power outage, which we have experienced, or a Wi-Fi disturbance. Regarding the questions of low back pain and sciatica, I think we got answers to that. Regarding degenerative changes of untreated scoliosis, it's something which maybe you're gonna get into the research base for patients who are followed for more than during their lifetime and see what happens in terms of the degeneration. But when we have surgery, we have more mobility required from the untreated segments. So I want to probably say goodbye to everybody. We tried and it looks like something is not working. So have a wonderful weekend, everyone. Have a nice summer. We're gonna see you in September. Hopefully you can join us to the Leon Method online school has a master course now, 3 levels, beautiful lecture with Dr. Jean-Claude Demeroy, and great practical experience as well. So we're taking new students from around the world. And then also you can join our Schroth Method educational programs online and in person. So we're looking forward to seeing you again in September. Have a wonderful summer and talk to you soon. Bye bye, everyone.